welcome to AO North America Journal Club on Talus fractures. We have my co-chair, Christopher Domes, and co-moderator for the evening. I'd like to welcome our guest faculty, Dr. Valier and Dr. Githens. Dr. Lindvall and Dr. Miller are unable to join us tonight, but their videos will be presented. And sincere thanks to all those joining us and for those sharing their videos with their interviews. These are disclosure information for the relevant parties, moderators, and faculty. Validation statement from AO North America for reading at your perusal. Please remember Zoom etiquette. All microphones in your have been muted and your videos turned off. All questions that the audience would like to present should be placed into the Q&A box. Well, Chris and I will help answer those and present them to the faculty. And the chat box is only for us, the faculty and staff. This is the series learning objectives for the Journal Club, but more specifically for tonight, to review the vascular supply of the talus in terms of how we apply it for surgical approaches and fracture healing, the key characteristics of talar neck fractures that affect outcomes, and to gain understanding of common long-term sequelae of talar neck fractures. This is our agenda with approximately 15 minutes per video, with 3 videos to present, and then followed up by hopefully a nice discussion up to about 9:10 to 9:15 p.m. tonight. Without further ado, we're going to start with the first video with Dr. Anna Miller, and I'm going to turn it over to the video now. Thank you so much. Hi, we're here with Dr. Anna Miller at Washington University in St. Louis, and she's here to discuss with us her article out of Hospitals for Special Surgery discussing the vascularity of the talus. Thank you for joining us.
Thank you for having me.
I just wanted to start out by asking, what was the prompting for you and your colleagues to perform this study, and what were you expecting to, what was your working hypothesis with this?
So this was a study I worked on when I was a resident, and this was led by one of my mentors in residency, probably my main mentor, Dean Lorich, who many of you know and have been influenced by. So basically, Dr. Lorich had started doing some vascularity studies with the femoral head a couple years before this, and I was involved in that also. And what he found was the MRI techniques they were using at the time at Hospital for Special Surgery were really advanced and, you know, kind of on the cutting edge of MRI use in the country. So we thought maybe if we look at these injuries that have a really high rate of avascular necrosis, like femoral neck fractures, talus fractures, we may find other vascularity maybe to help us learn what we need to protect more. But also our hypothesis was actually that we would see more than what we've traditionally learned from the textbooks. And the reason for that is most of the older studies are like the latex injections, where you can kind of see the arterial supply to the bone and dissect it out, but it's not very, very high resolution because you have to get the latex into those vessels. So what we learned on the femoral neck study, or the femoral head study, is that we were seeing a lot more kind of unnamed vessels, really tiny vessels that probably give a lot more vascular supply than we originally gave credit in that area. So our hypothesis really was that we would probably find more than what's traditionally been described, and then maybe give us some answers on why not every talus that gets a neck fracture goes on to avascular necrosis.
Awesome. And with the results of what you found, how has that changed what your mentors did and what you've done in your practice with respect to talus fracture care?
I don't think it has made a huge difference in, you know, everyday practice. I think the biggest thing is to help us just understand that there is more than just the traditional kind of 2 areas of blood supply, and that a lot of the blood supply comes from the posterior. So one thing that I would definitely try not to do is really dissect all the way around the talus, and we rarely have to do that. Sometimes when you're doing the medial and lateral approach, you may see that it goes across because of the trauma, but the only time I've really had that concern is when we've had some irreducible talus, And then you're really trying to get around and figure out what is keeping it from being reduced. And I try to be very wary of, completely cutting off all these great collaterals that you can see in the figure from the paper. The other thing that I learned just doing this actual study, we did the, injections, we did the MRIs, and then afterwards we dissected out every single talus and actually pulled them out of the cadavers. And I found it very interesting that you could ever have an extruded talus, because it is impossible to get those things out. It would take forever to cut every little connection that's holding the talus in place, and it was shockingly hard to get them out. So whenever I see a dislocated talus or an extruded one, I always think back about how hard that was to get out. So it is interesting. So I would just say, back to your question, not a significant change, but just to be continuously very careful with the dissection, but also to know if you get in there and it has already been completely destroyed, underneath the talus, like where we normally think of the blood supply, or in the sinus tarsi, we're not, giving up on that patient. They can still have a significant blood supply from the posterior in particular.
I guess the scenario that comes to mind is if you have a patient with a talar neck and or body that you would fix from an anterior dorsal dual approach as a medial and lateral, but someone who also had a significant posterior medial or posterior fracture, would that give you pause on doing a third approach, a posterior medial approach, and saying whether you would try and perform reduction of fixation through some anterior based means or percutaneously only? Like how do those injuries, I know they're more rare than not, but how would you approach those in the setting of this?
Yeah, I definitely think that's a great question. Again, rare injuries, but for me, I definitely think if you can, at least try to preserve one area of the blood supply. So, which probably in that case, it would be whichever one is more displaced, you would have, some idea that that's probably the more disrupted blood supply. So maybe if the neck's more displaced, you're doing your regular 2 standard approaches, and then you maybe try to do percutaneous clamps or something else for a posterior part. But yeah, I would definitely try not to dissect all the way around if possible.
Okay. Is there anything, with having done this study, is there anything that you, in retrospect, or your colleagues would have done differently, or that you've seen done in subsequent cadaveric studies looking at vascularity?
Yeah, I think the one thing I would really like to do, not that we would do it differently, but kind of part 2, or maybe even the more interesting part of the study, would be to do it in patients who actually have a fracture. Either an actual patient with a fracture would be pretty challenging to get that, protocol done before you're trying to get them fixed. But even, doing a cadaver study, but where you do an osteotomy of the talus and then inject it and see where the contrast or fluid goes, and see, how that disrupts, like doing a pre and post osteotomy kind of study, I think would be really interesting to kind of prove that blood supply, and maybe even see how the circulation or the collaterals change that blood supply after the osteotomy occurs. I also think it could be interesting to do a similar study after you fix the fracture. So in a live patient, if you did a study where you did these MRIs after the fracture was fixed to see what the circulation is, does that predict whether it's going to get AVN or not? Studies like that I think would be interesting. I think there are a lot more future studies that can be done, but I don't think there's a lot more to this. There is a paper that we published. There's one of the figures is the same from Foot and Ankle International in 2010. And we actually wanted to publish this paper first, but it just, with the editorial manager and everything, the other one just happened to get published first. So the figures got a little confusing during that time. But the other one is really looking more at the arterial anatomy itself. And I think the combination of those really kind of covered everything we wanted to with these studies.
For you, when you have these come in talar neck displaced fractures with associated dislocations or other extensions, what are your first things that come to your mind when you're teaching the residents and fellows in your institution?
Well, I think the first thing is obviously to get the patient reduced. For us, it's always kind of controversial about, do they need an X fix, or how urgently do you need to get the fracture fixed? I think in general these days we all agree that the best fracture fixation is probably going to give you the best outcomes as opposed to the fastest fracture fixation. So we're not generally doing these, in the middle of the night unless it's an open something or something that's irreducible. But that's kind of the thing we really try to teach the residents, is that we're trying to get the best fixation. And we definitely harken back to Dr. Vollier's landmark papers often to talk about, the AVN rates after these kinds of injuries, and just letting the patient know how severe the injury is, and that really the original displacement is probably the biggest predictor.
Well, I sincerely thank you for your time and discussing your article, and we look forward to seeing you at the live event.
Sounds great. Thank you. Have a good afternoon.
You too. So I'm here for AO North America Journal Club discussing talus fractures with Dr. Eric Lindvall in his JBJS 2003 paper regarding the open reduction terminal fixation of talar body and neck fractures. Thanks so much for being with us tonight.
Thank you for having me.
I'd like to start out by asking, what was the prompt for you and your colleagues in Tampa for performing this study?
So really, I think it really had to do with, in the treatment of these fractures, it was kind of unclear in the literature as to what the true incidence of osteonecrosis versus post-traumatic osteoarthritis were, because so many of the studies had limited follow-up, or they had non-displaced fractures, or they had associated articular fractures. So our goal was to try to clean that up and kind of look at the isolated displaced fractures of the neck and body, and then kind of report on the results of that.
In your findings in the paper, what are the major takeaways that you, to this day, almost 20 years later, find to be the key or most important takeaways from your manuscript?
So I think it has to do with probably the long-term outcomes that we were able to find, because the study had a minimum of 4-year follow-up. So it gave us kind of a benchmark as to what's expected long-term. And we found that in the displaced fractures, at least, they really end up with 100% end up with osteoarthritis, some form of it, and then also with some form of discomfort in that ankle. So knowing those two things, that helped with our future counseling and such like that. The treatment piece, I think, piece we did find, we were able to maybe not have to rush out of bed in the middle of the night to fix these with the intent that it wouldn't end up with AVN in the future. Although in this time frame, we were trying to do that because that was kind of the reported procedure or technique to avoid the AVN. So after the results of this, we kind of were able to look at it and maybe say, hey, you know what, some of these maybe can get reduced and spit in a splint overnight and then get done the next day.
So that's something that for you, from the development of this to how you practice today, has changed in terms
Correct.
of
Yes.
Is there certain key phrases or things you try very hard to convey to your patients at the time of injury and as well in follow-up? That what type of things do you say to them with respect to outcomes?
Yeah, I think that's important, because their expectations, once known at the beginning, help the treatment course and their outcome, just because of the way they frame it and look at it. So part of that discussion, it really is about the AVN, about the osteonecrosis possibilities, and then the fact that the arthritis does form long-term in some form. We try to explain to them that will occur, whether it's symptomatic or a real problem for you, we don't know. But if you were a runner, maybe you want to rethink that and start taking up cycling or those kind of things, but not with the intent to decrease their activity level, but maybe modify it so they're not hampered more by the injury.
Within the body of the manuscript describing the methods, it's discussed that there was CT scans obtained in addition, and possibly MRI. Can you talk about the use of advanced imaging post-operatively that you used in the manuscript, and if you use it now?
So personally, I don't do a lot of post-operative CAT scanning. I think the radiographs are kind of indicative of their symptoms, meaning if we see some arthritic change or if we see some type of AVN collapse, but I think the MRI initially in our study, we were using them because we were trying to make sure there wasn't a form of AVN and trying to use titanium screws and those things to avoid more artifact. But I think over time, I'm not sure that's as relevant because the x-rays can truly find the arthritic changes. We can see the collapse of the talus. So routinely, I don't personally get post-op CAT scans. I think the pre-op setting, it's really important to do that just because you can assess and plan the surgery. But I don't find a need personally to get them often post-operatively, only because we can see those changes on x-ray.
Gotcha. You mentioned the use of titanium screws. Could you touch on the fixation used in this manuscript and how yours has either stayed the same or evolved in the last several years?
Yeah, so back in this day, obviously cannulated screws were the technique and the plates were kind of a thing of the future still. And now I know a lot of people that have published on this have gone to plate fixation in certain instances. I think it's very valuable in certain situations where there's a lot of common use and you're afraid of over compressing and ending with a varus angulation or a deformity. But I personally haven't used a lot of plates because I think they are a little bulkier and they have some other symptoms from those. So I personally have been able to stick with the screws. We'll put in the side that's maybe not as common at first to avoid the over compression, and then a position screw on the opposite side where the collapse may occur. So I haven't personally used much in the plating realm, but I know others have and had success with it. So okay. I guess to answer your question, I still stuck with the similar fixation type, but I know others have been successful with the plating.
Gotcha. We just touched upon fixation. Is there anything with this manuscript that after you and your colleagues, after it was accepted and published, is there anything you would look back and do differently to help add to the strength of the paper or to do differently?
Yeah, I think in hindsight, we would have liked to add more patients, right? I mean, I think most studies would say that, but in this instance, you know, others have published with greater numbers. And I think we ended up with such a small number because we tried to turn into just the isolated displaced fractures. So we ended up knocking out a lot of cases because they had associated medial mals, calc, some other thing that may cloud that true incidence of osteoarthritis. Yeah. So we tried to limit it. So in hindsight, we could have lengthened it a little bit, waited a little longer and pulled in more cases, which would have been nice. Another thing would have been possibly to use a different outcomes measure. We use that, you know, the ankle scoring system. Yep. The AOFAS, and we probably could have gone to the SF36. I think in hindsight, we commented on that in the paper, yes, but that may have been a little more relevant outcome measure according to our current standards. So.
Gotcha. Is there, in terms of future research, do you think that there's a specific area that you would like to see answered in the literature regarding these injuries? Or specific question, excuse me?
Yeah, so I think, I guess to that question, in a bigger sense, I think gross anatomy is one of those things where once you kind of discover it, I don't think there's a lot of change that occurs with that. Hopefully not. I know we're still evolving in some fashion, but I don't know how much of our anatomy is. But with that being said, I think the rest of the literature body, just because technology changes, techniques change, I think that's always relevant to continue publishing on items like this that may, in the end, do better with plates or some other thing that comes about at a later date. So to answer your question, I think there's always relevance to new studies, either to confirm what we thought before or to show different changes in the future. Okay. I think gross anatomy studies are one of those that may not be as relevant to that, but yeah.
Gotcha. And then when you have these injuries come in, what are things that you know, what are the top 3 things you ask or make sure that your residents or trainees know in California regarding these injuries?
So the displaced fractures, you know, the Hawkins 2 and 3s, we go after those reductions in a closed fashion if they come in the evening time or nighttime, because OR axis gets tricky and things. So we'll try to do those in the morning. But I think a reduction is important. Although we say in here that maybe timing is not as critical, I think we could have added the fact that a reduction of that fracture would be beneficial. I can't believe leaving it unreduced would be of any benefit. So, and most of them will reduce reasonably. You know, sometimes the body will stay spun in the joint, but I think a lot of times the neck will come in reasonable alignment and the subtalar joint can reduce. So I think that's a beneficial move that we try to get done early and avoid just leaving it displaced overnight.
Great. Well, I really appreciate your time and for joining us for a discussion of your article. And thank you so much for joining us tonight.
Thank you for having me.
So I'm Chris Domes at University of Wisconsin. I'm joined here by Heather Valier. We're here to discuss her paper, A New Look at the Hawkins Classification for Talar Neck Fractures. Which features of injury and treatment are predictive of osteonecrosis? So thank you so much, Heather, for joining me for this portion as well as the live portion.
I really appreciate the opportunity. Thanks so much for inviting me.
So we'll start with our first question. What inspired you to take a closer look specifically at the Hawkins classification?
Yeah, so for many years, things about the Hawkins classification have bothered me. And, you know, Hawkins did a lot of work and developed this classification, which I think is very easy to remember, easy to use. Most orthopedic surgeons know what it is. And so it's widely used, widely available. Yet it really leaves something to be desired in terms of the Hawkins group 2, that group that could either be subluxation or dislocation of the subtalar joint. And we can agree that whether it's completely dislocated versus just minimally displaced with no dislocation of any of the peritalar joints, that's going to have different ramifications on the surrounding soft tissue and also potentially on the blood supply. And so for many years, I felt like it would be nice to look at that, yet these are such infrequent injuries, it's difficult to get a large series of them to actually look at it and decide, is there a way to modify the classification, because there's probably a difference in prognosis from what we ended up calling a Hawkins 2B with a subtalar dislocation and a Hawkins 2A with no dislocation and just some displacement at the subtalar joint. And so you know, you read the paper, and the paper shows a difference in osteonecrosis. In fact, there was no osteonecrosis in any of the Hawkins group 1 or group 2A injuries. So I think that that point has been made. Now, at the same time, there were some other things that we really wanted to look at in this sample of patients. And one of them had to do with the fact that much of the prior literature focuses on the timing of fixation. And we understand that the timing of definitive fixation doesn't appear to affect the rate of osteonecrosis. And nobody was really looking further back to say, well, what was the timing of the reduction events? The timing of the reduction events is really probably what matters, because if it's dislocated and there's some tension on the blood supply, some pressure of one of the displaced fragments on the blood supply, then by reducing it, you should alleviate that pressure and potentially reduce the risk for osteonecrosis if the vessels are still intact. And so, again, that's another thing that had not been studied. And so one of our goals was to look at that. And then I might say a third piece that has intrigued me and continues to is this idea around the presence of a medial malleolus fracture. And so a medial malleolus fracture would imply that the deltoid ligament is still intact, and that any branches, be it the deltoid branch off the blood supply to the talar body, would still be intact if those soft tissues were intact to the medial malleolar fracture fragment. Hence, having a medial malleolar fracture may portend a better prognosis in terms of a lower risk for osteonecrosis. Obviously, those are even less frequent, seeing as you probably have to have a tibio-talar dislocation, so meaning a Hawkins group 3 or a type 4 injury with a tibio-talar and a talonavicular dislocation in order to look at that. And so the numbers get even smaller and more difficult to study. But those were the things that we really wanted to look at in greater detail.
So you hypothesized that delayed reduction affects osteonecrosis. However, we weren't really able to see that, likely because of underpowering of the study. Do you think if you had more subjects to follow over a longer period of time, you would have seen that a delayed reduction affects the amount of osteonecrosis these patients see?
Yes, I definitely do. But as you stated, it's even more difficult now to get those patients, because I think that as we get further along in time, people are more familiar with the importance of expediting reductions, not just of the talus, but also of other parts of the body. And so these patients with long periods of dislocation are becoming less and less common. And so we didn't have enough in this study to show a difference in the timing of the reduction event in terms of osteonecrosis risk, but it just makes sense that it should have an impact.
So Heather, how has this paper changed your practice?
I would say that this paper made me feel more comfortable with my practice. When I first started out, there were a few papers that had kind of suggested that the timing of fixation didn't matter, but there's still a lot of controversy, even amongst seasoned orthopedic trauma surgeons, about waiting and really fixing these fractures on a delayed basis, allowing the soft tissues to recover and all that sort of thing. And well, I felt fairly convinced in my mind. All of the people that I worked with in my first job were not of that mindset. And they had, throughout their careers, looked at these, whether it's the middle of the night, weekend, and come in and expeditiously done those reductions and definitive fixation on an urgent basis because they believed that the risk of osteonecrosis was better. And they weren't alone. I think that's a fairly widespread practice. And so while it frustrated me a little bit, we continued to banter amongst ourselves, and I took a different path, and we were able to get enough numbers, I think, in our group to convince each other, like, hey, this is a better way to go. If we can get things reduced, let's wait for the soft tissues, let's wait for the patient to be healthier, whatever it may be. And so I feel like there's a little more credence to that, and there's also a better consistency amongst the people I was working with in terms of how we were managing and that we can exchange those ideas and do better. A couple other things about my practice has shifted in that when I first started out, we didn't really have a lot of implants. There were very few mini fragment type implants available. And so you're really stuck with a handful of, say, 2.7 millimeter screws and small fragment implants, not many plates. And so now we have a variety of very small plates, 2.4 millimeter screws that are longer, and just a lot more versatility in implants. And I think that particularly with fracture comminution or with smaller fragments, things involving the lateral process, we have a lot better ability to strategically place implants that are going to retain our fraction position better rather than maybe neglecting to stabilize smaller fragments with screws because we just didn't have anything to put in there, and you're sort of stuck with leaving the Kirschen wire in, and I'm not a huge fan of doing that. And so I think that the implant choices are vastly better, and they continue to learn and try new things. And I think that that's been an improvement in my practice and in just the practice in general of fixing talus fractures and other periarticular injuries.
What are the main things that you want people to walk away after reading this paper?
So I would say the primary thing that I hope they would take away is that it's appropriate to divide Hawkins group 2 into types A and B. And so type A being just a subluxation or minimal displacement at the subtalar joint versus B being a frank dislocation of the subtalar joint, because there's a vastly different prognosis for osteonecrosis. In this series, there was no osteonecrosis with 2A versus a small percentage, which occurred only after 2B or more initial fracture displacement. So I think that's a key takeaway. I think the other pieces that if you read the whole paper are important to remember are that this paper reinforces that the timing of fixation has no effect on osteonecrosis. Now that had been shown in a couple of other prior series, but I think it's further evidence to support that, and that the timing of reduction of the dislocations probably matters. It's discussed quite a bit, but we had a mean time reduction of just 9.5 hours. And so with that being so fast on average and the whole series, just with several dozen patients, it really doesn't lend itself to the power to do that. I think that the fact that these were reduced and fixed almost all through anteromedial and anterolateral dual exposures, again, gives further credence to the importance of using a surgical tactic that will allow you ample visualization and ability to place strategic fixation through those windows. I've met a lot of surgeons who are very apprehensive about doing the second incision because they feel like that's an osteonecrosis risk. And while this paper is not designed to study that, seen as like 95% of the patients were treated through dual exposures, I think it does support the fact that these osteonecrosis rates are actually pretty low compared to prior literature. And so if there were a iatrogenic factor from just doing the 2 incisions, I think we would be able to see that or hypothesize and speculate about it based on this series.
Well, thank you so much for all your time and effort in helping us discover more about talar fractures. Dr. Valier, thank you so much for being part of this webinar series as well. We really appreciate all the work you've done and continue to do in helping us be better surgeons.
All right. So we're going to switch to the panel discussions. I'm going to start to share my screen again. Bear with me. So, Chris, I'll let you take it away with the first question from the audience.
Yep. And if you guys do have questions, please write them in the question and answer area, and we will present those or answer them through there. So one of the questions that did come up, and Dr. Valier, you just kind of briefly touched on this in our video, is have there been associations with avascular necrosis depending on the approaches that are used? I know the paper that Dr. Valier, you primarily looked at the anterolateral, anteromedial, but do you guys know of any other approaches that people should frankly stay away from when addressing talar neck fractures?
So that's a really interesting question. And I think this continues to come up, and it's really a function of everybody's experience being different. With a very rare injury, people learn from people who do, a handful of these and they pass on their pearls. And so there's these little pockets of practice and thought. And so that's a common concern. It was obviously mentioned just at the latter part of that video we just did. With the 2 incisions, I think it's important to keep in mind that you should be using sharp dissection down to the level of the talar neck, stripping the portions of the talar neck that are in line with the medial or the lateral approach, depending on if you're in the anteromedial or anterolateral window, and avoiding dissection dorsally over the talus, because there may be some remaining blood supply that's coming in there, to make sure you're not damaging it. But probably even more importantly, that you're not dissecting inferiorly. In particular, we know the deltoid branch enters and is probably a main part of the blood supply that exists despite dislocation events. And so I think with careful surgical technique, the 2 incisions appear to be safe. That being said, there's really no direct study that looked at that and compared the 2 incisions versus just an anteromedial approach, which was kind of an older way of doing it, or just an anterolateral approach. Now, there's a large series of patients that was presented year before last at the OTA. I believe it was 22 centers, presented by Max Alley with Paul Tornetta as his mentor out of Boston University. And they had close to 800 talar neck and or body fractures. I think 610 of them were talar neck fractures. And they did a lot of different analyses looking at various injury features and surgical approach features, and noted that the patients with dual anteromedial and anterolateral exposures did have a slightly higher risk of osteonecrosis. However, it's difficult to compare because it was very surgeon dependent. So I think that there may be an element of surgeon and center performance in terms of the nuances of the technique. And that's purely my opinion and speculation, because I just don't think we have enough information to know. To your point about using some type of an alternative exposure, I'm not aware of another tactical method to really give you the visualization to accurately reduce the fracture and to strategically place the implants. Many years back, people used to do it posteriorly, which was really difficult to wrestle into position. There was really no direct visualization available, and I would not advocate that.
Dr. Githens, do you have any additional commentary on your surgical approach planning? Any pearls with respect to that with the question from the audience?
Yeah, I don't think that I have a lot to add to that. I think that I very strongly agree with a meticulous dissection, being aware of where the perforating vessels reside. If that area is stripped, then you have to assume that those vessels are out and you may need access to the fracture for reduction there. But if it's not and you don't necessarily need access, then I strongly agree with not over dissecting just to develop a greater fracture visualization plane. And I think Dr. Miller mentioned this in her video, but I think where this becomes challenging and troublesome is when you've got a complex combined pattern where you've got And this was, I think, Dr. Tallarico, your question specifically, a talar neck that's going to need dorsomedial, dorsolateral approaches, and then a posteromedial approach for a posterior body fracture, which we don't see infrequently. And in those cases, the question is, is it reasonable for me to make all three of those approaches? And part of that decision-making process is, what is the injury pattern? Dr. Villiers has already talked to us about, the increasing risk with increasing joints dislocated. And in most of those cases, you have two, if not, subtalar and tibiotalar joint dislocations with the body spun and the posterior part comminuted. So I think your strategy may shift at that point, in that your goal is restoring the morphology, the osteology of the talus, and with the thought of this may go on to avascular necrosis, they may need additional operations. But if I can provide them with a normal shaped talus, that will provide the easiest salvage operation. And so part of this is a chess match and looking down the line and trying to decide when do I need to make three approaches. I will do them as safely as possible, but in my mind, I think reconstructing the architecture of the talus is very important when it comes to the down the line salvage options. So I think that's where this conversation gets challenging in regards to the preserving blood supply, but with multiple approaches.
Nice. Thank you both.
Another question is, as implants have changed and maybe we're not getting as many MRIs, are people, or Dr. Villiers, Dr. Githens, are you guys using primarily titanium or just normal stainless steel implants at this point? Also, are you guys primarily using cannulated type instrumentation? What's your practice like now?
I'll lead off on that one. I don't use titanium implants anticipating advanced imaging. I agree with Dr. Lindvall's points in that, and I guess I would even add to his points, there are a subset of injuries that I anticipate problems with in regards to AVN. And of course, this is the whole purpose of Dr. Villiers' paper, is if you've got a 2A versus a 2B or a 3 or a 4, then that one I have a completely different post-operative approach to. And I'm not, in my practice and in my partner's practice, I don't really see a role for advanced imaging. So I'm not altering my implant strategy so that I can image down the line. I already know kind of what I'm looking for clinically, time course, and radiographically on plain radiographs. So that doesn't affect my implant strategy. And then in regards to cannulated versus not, versus headless compression screws versus lagging by technique, in my opinion, a lot of that comes down to sort of the size of the hole that you're going to put in the talar head, right? Like these are, and the way you're generating compression, and most of these fractures, if it's compressible, it's clampable. And I'm not sure that you're going to generate any greater compression with some a headless compression type of screw, cannulated or not, as compared to lagging by technique. The size of the hole that you're going to put in the cartilage for countersinking or sinking that screw is about the same diameter. So in my practice, it's a standard cruciate head 2.4 millimeter screw. I like smaller diameter screws so that you can get multiple points of fixation and multi-fragmentary fixation without running into issues regarding real estate for implant placement. I do think that one of the nice things about using cannulated screws, if you have a wire that's in the perfect spot and you want a screw there, it's pretty easy to put a screw right over that wire. But conversely, you can easily exchange that wire out for a small diameter screw. So in my practice, I'm using standard inexpensive implants with your sort of classic AO techniques in order to obtain compression and fixation.
I think my practice is fairly similar to Mike's practice. And so I don't have experience with planning for an MRI because I've always been of the philosophy that if the patient does develop osteonecrosis, I'm unlikely to obtain an MRI scan to diagnose that or to assess treatment, we can recognize it on plain radiography, and in the absence of a Hawkins sign suggesting that the patient is going on to osteonecrosis, we encourage them to begin weight bearing, and so we don't alter the management other than to follow them closely to watch for collapse or other sequelae that may occur. And so I don't plan for MRIs, and I don't use titanium implants. I feel like a lot of the titanium implants are sometimes more expensive, and they're also, they just have different properties when you're using them. And so I prefer stainless steel, find it easier to work with, more readily available, easier to remove if you need to take it out. And so I like that. I don't have experience with cannulated screws in the talus. I use exclusively small fragment and mini fragment type implants. In terms of screw size, I will use 3/5 screws sometimes as axial screws, and or 2/7 screws, sometimes a combination, one of one kind and two of the other kind. But I tend to countersink them through the head of the talar cartilage. I like 2/4 screws and 2/0 screws with cruciform heads, and those are nice because you can sit them right on down. And I've tried some of the headless compression screws, but I haven't been impressed with it. I just think that that's expensive and it's very fiddly, and I don't think it really matters. Most of the time, these fractures are comminuted, so you're not necessarily achieving compression through your screw placement. And in terms of the cannulated screw, they're vastly more expensive, usually 15 to 20 times the price of a single non-cannulated screw. And it's really inferior in pull-out strength because so much of the thread, the depth is compromised by the cannulated portion of the screw. And so it's been my preference in general to avoid using those, aside for just very specific parts of the body.
So to follow up on this discussion, if I may, I'd like to ask a question of the panel, sort of shifting the focus back to the injuries on the far end of the spectrum, the one where you've got maybe a comminuted talar neck, some peripheral associated fractures, and then the body is spun and dislocated. This is one where you are anticipating if anyone is going to develop avascular necrosis over, the 6 months to 2 year period, it's this one. So in that patient, aside from watching very, very closely and listening to the patient's symptoms, are any of you doing anything else in anticipation of that? And what I'm honing in on is, Dr. Valier, in your paper, you guys identify that there is quite a number of people who developed some degree of osteonecrosis, but not collapse. And so in that specific patient population, are you saying, I'm expecting some degree of AVN? What is in my armamentarium to potentially prevent collapse, pancake talus that needs some complex salvage operation? Is it just a watch and wait, or is anybody doing anything else?
I'll go first. I had one that I had a young woman with a large posterior body fragment that also I did use all three approaches, and I've watched her for 2 years, and it was mainly just observation and consultation with one of my foot and ankle colleagues for workup of, she did develop osteonecrosis and she did have some collapse, but it was mainly just the talar dome and not complete otherwise, and otherwise maintained her alignment. So it's mainly just observation, waiting for her to elect if she chooses to have another procedure. But I've mainly only been in practice for 5 years. So for me, my short answer is observation and counseling over as long of a period of follow-up as I'm able to do with the patient.
Yeah, I concur. Just to emphasize that point, you're going to see osteonecrosis, and when you first see it, you're usually not going to see any collapse or irregularities of the joint with it, and about half the time, it will revascularize. And so I think just educating the patient, counseling them to notify you if they're experiencing some change in their symptoms, but otherwise scheduling regular follow-ups approximately every 2 months to come in for plain radiography, and then explaining that if there is some collapse, they may or may not be very symptomatic from it, and that there are pain relieving procedures that can be undertaken should they be indicated down the road. Although more often than not, the patients in our practice really didn't end up getting salvage procedures either.
Yeah, for me, it's really the same, watching, and very few of them have had to go on for secondary procedures, at least, 5 years in. How about yourself, Dr. Githens? Is there anything that you have found to work or that you think might work on those patients?
Yeah, I think this, this is kind of the challenging window of managing these patients who have the worst injury. And I think it's interesting, and I think it's an area for further exploration, because I don't know that just purely observation and early detection is super important. And when somebody starts to develop it, you got to say, hey, this is what's happening. Got to keep a very close eye on you, and here are the next steps. But I think that there may be more that we can offer, or at least sort of avenues that can be studied. And one thing that we've been doing is starting to put these patients into the dynamic custom fit hindfoot offloading orthosis, an orthosis that will take the load and transmit it from the midfoot to the tibia and offload the hindfoot and the tibio-talar joint. And this is anecdotal, right? There is no good evidence to support this, and these braces are expensive, but I do think it's a future area for study, because if you think about what happens with these patients, they're doing really well. They're making incremental improvements. They're doing well. They're getting back to their activities. You're following them closely, and all of a sudden they have sort of this precipitous decline, and they come in with a pancake flat talus. And so what we've been doing is, in this subset of patients where you say, hey, look, like, more likely than not, based upon your injury, this is going to happen. So as a preventative strategy, we've started putting patients in those braces. I can't say because we haven't studied it, but anecdotally, it seems like they're comfortable, they help the patients, and perhaps when the talus is revascularizing during that process, it may prevent collapse. Again, not advocating this to all of the listeners as something that we're recommending as a carte blanche treatment, but I think it's something to consider. I know folks who have actually, once you see early evidence and symptoms related to avascular necrosis, actually put a distraction frame on, which seems very aggressive to me. But you're also talking about potentially saving the patient's talus. So the only reason that I bring that up is because we talk about the mainstay is early detection, symptomatic management, and then salvage procedures. But there may, in my opinion, may be a window where we could intervene and prevent that collapse. So I appreciate your guys' comments.
This is really interesting. Can I ask you a question about that?
Yeah.
So I've heard about using external fixation distraction, and I just kind of anecdotal. A couple of people have like one or two cases, and so it's fascinating to me. But I'm wondering a couple of things. When you apply that orthosis, are you noticing disuse osteopenia in other parts of the foot and ankle just because they're not loading the joints the same way? And then also, is there some concomitant diminution in muscle strength and flexibility, again, from more protracted disuse than if they were to restore as normal as ambulation as they can? And then I guess my second question is if they're going to collapse, do you really think it's going to prevent them from collapse? I mean, you're going under the theory that while they're a little bit more protected, they're going to have more time to revascularize. And if so, then how long do you continue with that orthosis?
Yeah. So to answer your first question, I think that the patients, we at least the ones where we've really are working close with, can follow up. We can follow their physical therapy. This is a brace that's worn when they're weight bearing, and we're really working on a subtalar motion, ankle range of motion at the same time with the brace off, right? So unloaded motion exercises. And so you do see disuse osteopenia for sure in those patients who are wearing them over, multiple months. In regards to the motion and the atrophy associated with that, really hard to measure and hard to know. But again, I think the patients that we do get into these braces are the folks who really are invested in their own care. And so they're working hard in physical therapy as well. To answer your second question in regards to the duration of bracing, and do I really think that it may provide so a window where you can revascularize in the absence of significant loading and perhaps avoid collapse. I think so. I'd like to think so. But in regards to the duration that it takes, I don't know the answer. I have absolutely no idea. But what I've found is the braces, because they're custom fit, inside shoe, underneath clothing, patients tolerate them really well. I've had very few patients say, can't stand it, I'm not going to wear it. And many patients who say, yeah, when I'm up and about, actually, I feel better. And it becomes a sort of an accepted part of, you tell them you've got a terrible injury and there's going to be all kinds of potential necessary interventions along the way. And when they get this low profile custom molded brace, it seems like not such a bad intervention on that spectrum that you've spoken with them about. So hopefully that answers your questions.
Yeah, thank you. That's very interesting.
I've had some good success with putting patients in those. The biggest issue in our region and what people hit against is just getting them and the access to somebody who can accurately and in a good fashion make those for our patients. That's been really hard coming from your region, Dr. Githens. We don't have quite the availability, but they, I think, help out symptomatically. One question that came up was what is Dr. Valier, Dr. Githens, your post-operative protocol for these that you do 2-incision plate screws fix?
I'm pretty basic. So I splint in the OR, encourage rest and elevation of the leg a lot those first few weeks, try to get the fluid out of the tissue. And then at the first post-operative visit, approximately 2.5 weeks post-op, as long as the wounds look okay, we'll do suture removal and start range of motion activities. If I have a completely unreliable patient, somebody who's a recreational drug user and or a super comminuted talar body fracture, I might use a short leg cast for 6 weeks or so, just to kind of protect them a little bit from themselves. And then normally they're moving and getting going in around 12 weeks. If it looks like the fractures are healed or nearly completely healed, I just have them do progressive weight bearing as tolerated.
Dr. Githens, any difference?
Very similar post-op protocol. There's the occasional one that has associated sort of circumferential soft tissue injury, not skin, but ligamentous disruptions and such that you need to keep in an external fixator, or fixation that you're concerned about that you need to keep in an external fixator. And I would say, and so those patients, I would say that's an important thing to sort of identify preoperatively, is say, hey, there are features of this injury where I'm really worried that even if after plate and screw fixation, I'm going to have some potential issue. Whereas if I leave this as it is, either gross instability or the motion, just physiologic motion may induce shear in a way that I can't trust my fixation, then I will tell that person preoperatively, we're gonna fix this on the inside, and then we're going to create a scaffolding on the outside to protect it. That's rare. And I'd say generally speaking, my post-operative protocol is very similar to Dr. Valier's. I think that early motion in the absence of shear forces, so non-weight bearing for 3 months, but early subtalar, ankle joint, and midfoot motion are very important in regards to sort of optimizing function.
There's been 2 additional questions, one of which kind of jumps off of the discussion of post-operative protocol and bracing. And in general, if you are justifying the use of certain special braces or custom braces, are there specific wording that you use for the orders, Dr. Githens, Dr. Valier, about for insurance companies and workman's compensation that needs to be in there for them to be approved, or things that you see?
That's a really interesting sort of point in this discussion, and I'm glad that was brought up. And it ties into the evolution, I think, at least in our institutional experience with these braces. And just going back to Dr. Dome's point, where accessibility can be a real challenge, I would say 5 or 6 years ago, were faced with a similar problem. And at that time, there was only one manufacturer of these sort of braces that we could send our patients to in a reliable way. But in order to get the insurance to cover it, the documentation had to say, this is the last option viable prior to an amputation. And of course, that becomes a big issue because then the patient reads their chart and they're like, whoa, we didn't talk about amputation. So I think that there are probably in certain regions, you're going to have to push your insurance company that hard. And the question is, well, is it really worth pushing the insurance company that hard when really that is perhaps the worst of the worst potential outcome, but unlikely that that's the case. So I would tell you that 5 years ago, that was part of the dot phrase in regards to justifying the use of some of these braces. But what that did was sort of force a more widespread coverage of these things. And now we don't really have to justify it other than saying I'm expecting, and I think a reasonable thing to say is I'm expecting avascular necrosis resulting in collapse of the talus, which necessitates further surgical intervention. And this device may prevent that. And then it's up to the provider in regards to how hard to push sort of whatever the specialty devices that you're looking for. But yeah, it's a challenge.
As part of that, before I get to the second question that was asked, is there a window? You know, we asked you about your post-operative protocols. Is there a window where you think that this potential offloading use of brace or distraction external fixator, is there a time window where you've seen this in your patient's follow-up here where you feel like this might be useful, or where you start to see the earlier signs of osteonecrosis? Is that something you can inform the audience about in your practices?
Yeah, so the bracing, I would say that I would put more eggs in the bracing basket than I would this distraction external fixation. I think that distraction external fixation is reserved for very specific patients in very specific settings. But in regards to the bracing, if you say, hey, I've got this subset of patients where I know this is a terrible injury and more likely than not, they're going to suffer this sequela, I tend to try to get them fitted for the brace once the swelling has come down. So at their 6-week appointment, if their wounds have healed and they look like they're starting to develop normal contours about the ankle, then that's time to send them to get fitted, because that process takes a couple of weeks at best. And then they'll have the brace by the time they hit the 3-month mark. They can start to ease into it. No patient is going to hit the ground running it, or most patients are not going to hit the ground running at 3 months. So you have the opportunity to ease into it for a couple of months. And then by the time you hit the 6-month period, you're really entering that window where you may be the patient who's going to suffer from early collapse. So I like to initiate the fitting before they're weight bearing, get them used to the brace as they start getting used to weight bearing. And then they're either gonna like it, and at least, again, in my anecdotal experience, they're gonna like it and they're gonna wear it when they're up and about, and they'll wear it for a couple of years until they say, hey, I'm kind of back to my baseline and I don't think I need this thing anymore. And I have, to be very honest, I've had a few patients who have worn the brace and still have pancake flat talus. Doesn't prevent it every time.
That's part of the reason why the brace was developed for severe, arthritic conditions, all kinds of things. So that kind of makes sense. It's very interesting.
Totally. And I mean, if you think about that, right, this is like to save the folks who have the worst of the worst articular hindfoot injuries. And it's really designed to treat post-traumatic arthritis. And so what you're doing is you're treating that, you're managing that symptom, but perhaps you're also preventing some collapse.
Thank you both. That's a very interesting thing that has been part of this discussion live, which I wasn't anticipating, which is great. Just to hammer home a point more about the surgical treatment is, are there certain characteristics that you're overnight when something isn't able to be reduced? Can you talk about, just to reiterate the points about timing to reduction and timing for surgery on when you would take these overnight that are not reducible?
Oh. So that's a great question. So most of the time, your Hawkins group 3 and type 4 injuries, you're probably not going to be able to get them reduced in ED. Sometimes you can get the 2B ones reduced depending on the injury and the amount of relaxation. And so those dislocations should be reduced and then splinted. Most of the time, I don't think you need an external fixator if you just splint it and have it be relatively congruous. But Sometimes you can get them to the OR, and just some general anesthesia will allow you to get it back in through closed means or through percutaneous manipulation. For example, a transfixion pin in the calcaneus, something that'll just give you a little bit more directed force to the peritellar joints to get it reduced. If all of those things fail for me, and again, I don't leave them dislocated all night. Like say the patient came in at 6 or 7 p.m., that would go to the OR then and get a reduction. If it came in at like 8 or 9 p.m., depending was I still around and, is there a room open, we'd probably just get it reduced. Once it gets past then probably it would go first case in the morning or maybe an hour before the trauma room starts. I think that's a little bit of a judgment call because there's like kind of a little bit of a dead zone there in the middle of the night where I might wait a little while, depending on the patient, the amount of time that it's been dislocated and the status of the soft tissues. If you can't get it reduced, closed or percutaneous manipulation in the OR, then you should do an open reduction. If it's a simple fracture and the soft tissues appear amenable, I may just reduce it and fix the whole thing then. But if it looks a little more complicated, I may just make an anteromedial exposure to facilitate reduction, get it reduced, and then close the wounds, splint, and come back in a couple of weeks and do the rest of the surgery. Now, occasionally I've had patients who have like very severe head injuries or a variety of other systemic things going on, and it's not feasible to sit in the OR with them for a couple of hours, which it's going to take to accurately reduce and fix this. But you can do some percutaneous manipulation or maybe just a quick open reduction. And so again, that's preferable than leaving it sitting dislocated for many hours or even days.
Thank you. In both of your clinical experiences, have there been common things that why the fractures have been non-reducible, fracture characteristics that you see on initial presentation or CT imaging that make you think this isn't going to be successful for a closed reduction?
Yeah, I think so for sure. Some of these injuries are wild. Like, I'd say that it's easy to sort of classify these as a 2B, 3, 4, but when you have body involvement, they can dislocate in any direction. And I think sort of, going back to the most common sort of structures to prevent a reduction, it's like anything. And so really what I found is that if this is something that is not closed reducible with good sedation, if not paralysis, there's more likely than not something really blocking that reduction. And getting a CT scan and really studying the dislocated fragment in relationship to the tendons on the medial side, the musculature on the lateral side, it is very helpful, because then that can help you, as Dr. Valier pointed out, is like, you may not have the opportunity to make multiple incisions and fix this thing. You may have the opportunity to spend 1 hour with this. And if you just put let's say the medial tendons are the problem and they're draped over the neck or the body, and you put a distractor on that, all that's going to do is tension the tendon, and it's going to make it even harder to get the thing reduced. So if you take the time to study that CT scan, look at the soft tissue windows, and then just go back to your anatomy book and say, all right, well, if this thing is flipped out posteromedially and I see a couple of things over the top and one over the bottom, then to me, that's where I need to make my incision in order to just simply flip those things out of the way, and then it's going to pop back in. You can pull all you want, but until you have identified the specific structure and address that, I think it can be very hard. So I would just push the audience towards really paying attention to that CT scan and understanding the dislocated fragment and its relationship to whatever soft tissue structures there are. I mean, if the body is the body and or the head, I mean, sometimes you have these weird shearing injuries where most of the talus is dislocated medially. You know that it's going to be some of the medial structures that are in the way, but then when you go to reduce it, you flip the medial structures off of it and it still won't go, and it's because you're buttonholed through the talonavicular capsule too. So I can't say that, commonly it's this or that. It's just really understanding the specific fragmentation and dislocation patterns, and paying attention to the soft tissue structures that are adjacent.
Yeah, I think Mike is speaking from a lot of really good experience and giving you some nice pearls for these cases, which are more often than not very challenging and frustrating. I think there's a tendency when you get in there, and most of the time the body is going to be dislocated posterior medially, sometimes other places, but particularly if there's not a medial malleolus fracture, it's really tight back there. So, you can try to give it a good pull, give it a percutaneous manipulation, open it, do the same thing. But having everybody in the room cranking on it, and suddenly you're into this tug of war and like, we're going to get this thing back in. And you realize like, okay, time out. Like, this thing's beating us right now. So we have to be smarter than it. Just stop and look at your tissues and kind of look at the tension of it and sort of see where things are at. And if you can do that and maybe floor it a little bit and play with it, you might just, by taking some pause to study, reflect, look at the imaging, ascertain some things that are hanging you up, and simplify the process. A couple of things that I've gone to, quite frankly, out of initial desperation many years ago, and then now I use them more routinely, are do a percutaneous Achilles lengthening. That'll give you just a little bit more slack in your tissues. And you can also do a capsulotomy posteriorly. I used to do it under C-arm, but now I just kind of do it through the anteromedial view, and you can sort of feel it with your finger. You can take like a number 15 blade and just feel the capsule and kind of cut the capsule in the back. And that's wonderful because it'll kind of just, you can feel the release and how much easier it is. It's still difficult, but you can really get control of the body then to get it back in. The other thing that works nice is taking a little 2.5 chance pin or a 3.040 chance pin and threading it right into the fractured edge of the talar body in like a corkscrew, and then you can kind of grab it and pull it back in. And sometimes in conjunction with your thumb at the back and then pulling from the front, that's just a little bit more mechanical advantage to try to get around it, because it's a slippery little bugger when it's stuck back there. And so those are a few things that might help you out when you're wrestling it in the morning.
Well, awesome. This has been an excellent discussion. And if the faculty are okay, we can go to our closing statements, let everybody get on with their evening. But I love that we talked a lot about patient counseling. Soft tissue handling was a huge part of it, and just even in the overnight reduction tips or irreducible. And that's what I was asked a leading question with the common things. But as Dr. Giffens pointed out, it's not always just common. It's pointing out all the soft tissue structures that it may be and understanding the fracture. So the take-home messages for today, hopefully with the videos and the panel discussion, is to apply the knowledge of the vascularity and adjacent soft tissue structures for planning the surgical approach and fixation, recognizing these specific injury characteristics that affect sequelae and outcomes, and then understanding the severity of these injuries with patient counseling for the development of post-traumatic arthritis and osteonecrosis. And I think that those 3 videos and papers highlight those all well, and we discussed those a lot in the panel discussion. So thank you so much to everybody. There'll be a link to the recording sent out through Zoom 24 hours later, and they're also available on the YouTube AO North America website. And then the last is a plug for the upcoming journal clubs. Please look for these in your emails. In August, we have pelvic ring resuscitation, and then September infection, followed by October clavicle operative treatment. You can always use the My AO app to make the most of your AO experience. Thank you so much, everybody. I really appreciate it.